Thank you so much, Dr. Praveen, and we will take the session ahead from here. I will be discussing a newer paradigm in the treatment of resected EGFR mutant early lung cancer. Thank you, AstraZeneca, for making me part of this session. So, 1 in 3 patients with non-small cell lung cancer, they present with a resectable disease. So we know that most of our patients, they will present in stage 3 or stage 4 disease, but still almost close to 35% patients, they will have a resectable disease. And the lung cancer is a leading cause of cancer-related death. It accounts for more than 1.7 million deaths annually. As many as that which are breast, prostate, and colorectal combined. So it is a single most important cause of cancer-related death. And it represents, NSCLC represents 85% of all the lung cancer, with the estimated 30% of the patients presenting with resectable disease at diagnosis. So this is a brief staging, something like staging. So stage 1B, it is localized early lung cancer, and the regional or locally advanced lung cancer, they are stage 2 and stage 3. So these are the outcomes in early stage NSCLC, and they need to be improved. So previously we just had surgery for early stage lung cancers and radiation, and then in 2005 we started using chemotherapy, which did not improve much of overall survival in these patients. Then a few of the clinical trials, they tried oral TKIs in EGFR mutant lung cancers, but they all had a disease-free survival advantage, and none of them had overall survival advantage. So it is still not a standard practice to use EGFR TKI in early lung cancer after resection. But we will be going through a trial which can place osimertinib in this line of treatment. So surgery is the main primary stay of the treatment in NSCLC patients, and adjuvant cisplatin-based chemotherapy is recommended for the patients with resected stage 2 and stage 3A NSCLC, and selected patients with stage 1B who have high risk disease such as tumor size more than 4 cm or poorly differentiated histology. The results from the large randomized clinical trials and meta-analysis showed that 5-year overall survival for the patients who had adjuvant chemotherapy in early stage breast cancer, early stage NSCLC. The overall hazard ratio was in most of these trials is 0.89. So please remember this overall hazard ratio of 0.89. We will be discussing about this hazard ratio in the ADULA trial. And DFS, it also favored adjuvant chemotherapy. Here also kindly remember the hazard ratio, it was 0.84 in the adjuvant chemotherapy arm. So overall, the disease recurrence or death following surgery or adjuvant chemotherapy remains high across the disease stages. And in stage 1B, the 5-year recurrences rate are around 45%. In stage 2, the 5-year recurrences are to the tune of 60%. And in stage 3, they are to the tune of 76%. So there is a huge need for improvement in these resected patients. So based on the limited number of this study, the prevalence of EGFR mutation, it appears to be similar across the disease stages. So if we know that most of the EGFR mutations, the highest percentage of EGFR mutations, they are found in the Asian population. And in our country also, the percentage of the EGFR mutations is to the tune of 25%, and few of the Asian countries, they have reported this percentage to be 40 to 50%. While the Caucasians, they have the mutations to the tune of 10 to 20%. So few of these studies, they have looked into the EGFR mutations in the early stage disease also, that is stage 1 to stage 3, and even in these stages, the EGFR mutation prevalence remains the same. So it varies somewhere between 30 to 50% in the Asian population to 19 to 40% in the European or US population. So if EGFR TKI were available in the resectable setting, a similar proportion of the patients may be able to get the benefit as compared to the advanced setting. So we'll be discussing here the role of role of osimertinib in the ADURA trial, in which the adjuvant therapy in the stage 1B to stage 3A EGFR mutant patients was given after complete tumor resection. So this is a phase 3 double-blind study, and the patients selected here were those patients who had completely resected stage 1B, 2, or 3A NSCLC with or without adjuvant chemotherapy. So they should have good performance status, more than 18 years of age. Then the EGFR mutations was must in this population, and maximum interval between surgery and randomization is 10 weeks without adjuvant chemotherapy and 26 weeks if the adjuvant chemotherapy was given. So 10 weeks without adjuvant treatment and 26 weeks after adjuvant treatment. So the stratification, predefined stratification was by stage, EGFR mutant status, that is deletion 19 or L858R, and this. These patients, they were randomized to the osimertinib, to the 80 milligram once a day or placebo. And the treatment, it was continued for at least for 3 years. So planned treatment duration was 3 years, or it could be stopped if there is disease recurrence, this treatment completed, or discontinuation criteria. So the endpoint here were primarily the endpoint were disease-free interval by investigator assessment in stage 2 and stage 3A patients, and it was designed for superiority and the assumed DFS hazard ratio of 0.70. So following IMDC recommendation, the study it was unblinded early due to the efficacy. So not due to the futility, but it was unblinded due to the efficacy. And here in this meeting, we are reporting the unplanned interim analysis of the unblinding of this study. So these are the inclusion and exclusion criteria for ADURA trial. We have already discussed in the previous slide, primarily the non-squamous NSCLC post-operatively stage 1B to 3A, and confirmed to have exon 19 deletion or L858R, and standard post-operative adjuvant chemotherapy was allowed, but it was not mandatory, and patients they had received 4 cycles of maximum chemotherapy. Complete surgical resection of the primary NSCLC and recovery from resection surgery and treatment following the surgery. And all of the patients, they were to have a baseline, and these were the exclusion criteria. If the patients they had pre or post-operative radiotherapy, pre-operative chemotherapy, EGFR TK if they have already taken, or if they would have been on the CYP3A4 inhibitors for in the last 3 weeks, and the time between the surgery and randomization not more than 10 weeks if the adjuvant treatment was not used, and 26 weeks if the adjuvant chemotherapy was used. Patients who have had only segmentectomy or VEG resections, they were also excluded. The patient need to have the lobectomy. So this is the baseline characteristic of the patients. Most of the patients, they were female. The median age was around 64 years, and mainly the patients who were here were Asian population. So we can see here that the ratio of the Asian non-Asian population was 64 and 36 in the osimertinib and the placebo arm. Baseline MRI or CT scan of all the patients had to be done in this trial. And adjuvant chemotherapy, 60% of the patients they had received adjuvant chemotherapy, and 40% they had not received any adjuvant. So these are the Kaplan-Meier curve for the predefined subset in this ADURA trial. Osimertinib, it improved disease-free survival versus placebo in resected EGFR mutant NSCLC. So if we see here, the hazard ratio for the median disease-free survival, it is 0.17 in the in those patients who had received osimertinib. While if we remember that this hazard ratio with the adjuvant chemotherapy was 0.84, so such a huge difference between the hazard ratios if we are using adjuvant osimertinib or adjuvant chemotherapy for our patients. So median DFS has still not been reached in this primary population, but for placebo it is 19.6 months in the stage 2 or stage 3A, and in stage 1B, 2 or 3A it is 27.5 months. So there is 83% reduction in risk of disease recurrence or death with osimertinib here, and 80% here, hazard ratio being 0.17 and 0.20. So 2-year DFS was consistent for osimertinib arm across the disease stages, 1B, 2 or 3A. You can see here that 2-year disease-free survival was to the tune of 88% versus 71%, 91% versus 56%, and 88% versus 32% in the ADAURA trial in the osimertinib arm. So stage 3 patients, they have most of the recurrences, and you can clearly see here that 88% of the patients, they had disease-free survival at 2-year mark. And see the hazard ratio here. The hazard ratio is 0.39, 0.17, and 0.12 in the various stages of the disease. If we see the subset analysis of the disease recurrence or death according to the investigator assessment, there was not even a single subgroup in which there was no benefit of osimertinib as an adjuvant treatment. So male, female, or whatever the age may be, smoking history, Asian or non-Asian population, and EGFR mutant status, that is exon 19 deletion or L858 beta, the drug was working well in all of them. So this is the early snapshot of overall survival in patients with stage 2 and 3A NSCLC adenocarcinoma. The median overall survival has still not been reported with osimertinib or placebo, but we see here at 2-year mark, almost the difference between the disease-free survival is approximately to be 7%, 93% in the overall survival, the 93% in the placebo arm and 100% in the osimertinib arm. Patients and investigators, they remain blinded to the treatment in order to facilitate the assessment of OS at maturity. So the data is still not mature, but you can clearly see here that there is 7% difference in the overall survival in stage 2 and stage 3A at 2 years. So these are few of the EGFR TKI trials in the adjuvant setting in EGFR mutant NSCLC. All of them, they had achieved disease-free survival, but not overall survival benefit has been demonstrated in these trials. So select study from erlotinib, Radiant study using erlotinib in adjuvant setting, Ivan study using erlotinib in adjuvant setting, or adjuvant CTONG study using gefitinib. So all of these trials, they had shown disease-free survival benefit, most of them, but no significant overall survival benefit. But if you see here, in all these trials, the hazard ratio was to the tune of 0.62 or 0.73 and 0.56, like that. But if we see the hazard ratios in the ADAURA trial, they were somewhere around 0.17 or 0.2 or 0.3. One of the important things to remember in the ADAURA trial is the type of recurrences that were seen in the resected NSCLC patient. So sometimes the local recurrences, they are salvageable in NSCLC patient, but if the distant recurrences occur or the brain recurrences occur in NSCLC patients, the prognosis become extremely bad, and these kind of patients, they don't survive much. So local or loco-regional recurrences associated with prolonged post-recurrent survival than distant recurrences affect that we know. And the preventing CNS recurrence is an area of unmet need in the NSCLC patients, EGFR mutant patients. So the CNS is a common site of distant recurrence among the patients with EGFR mutant NSCLC receiving EGFR TKI. And in adjuvant Radiant study, 37% of the patients with EGFR mutant NSCLC treated with erlotinib had the brain recurrences, CNS recurrences. So in Radiant study, there were 37% of the patients who had CNS recurrence even when they were kept on EGFR TKI. But osimertinib has been known to have a significant exposure in brain compared to the other TKI with good blood-brain barrier penetration. And in advanced NSCLC setting, first-line osimertinib, it has demonstrated consistent superior survival and 52% reduction in risk of CNS progression. So we can expect that this drug will have some overall survival advantage, and it will be a standard of care when the final overall survival matures. So important to know in this ADAURA trial what were the type of disease recurrences in different patients. So when the data, it was unblinded, 11% of the patients in the osimertinib arm had recurrence, while 46% patients in the placebo arm, they had recurrence. If we see the type of recurrences, 36%, 38% of these 11% patients, they had a distant recurrence, while 62% patients, they had loco-regional recurrence in the osimertinib arm. While if we see the placebo arm, the 61% patients, they had distant recurrences. So just the opposite of what we are seeing in the osimertinib arm. And 39% patients, they had loco-regional recurrences. So these are the site of recurrences in these 11% patients who had recurrence when the data was unblinded, and 46% of the patients in which the placebo was given. So if you see just 1% patient, they had CNS recurrence in the osimertinib arm, while 10% patients, they had CNS recurrence in the placebo arm. Similarly, we see the lung recurrences, the lymph nodal recurrences, they were less. The loco-regional recurrences, they were more in osimertinib arm as compared to the placebo arm. 6%, 6 plus 3, 9% patients, they had loco-regional recurrence, while 18 plus 14% plus 10% patients, they had the systemic recurrence in the placebo arm. So overall, 45 patients, they had CNS DFS events. And if we see the osimertinib, just 2% patients, they had CNS recurrence. So the CNS recurrence was seen in one patient, while one patient had died. And 11% of the patients in the placebo arm, they had CNS recurrence. This is CNS DFS in osimertinib versus placebo. So CNS DFS in placebo arm is 48. So median CNS DFS in placebo arm is 48.2 months, and osimertinib, it has still not reached. So at 3 years mark, 98% patients in the osimertinib arm, they are CNS DFS free, while 82% patients in the placebo arm, they had CNS DFS free. So close to 16% patients, they had CNS recurrences there in this trial. This is statistically significant, and if you see the hazard ratio here, hazard ratio is 0.1. So these are a few of these adverse events associated with osimertinib. So whenever we are giving osimertinib for a longer duration of time, we expect fewer of the side effects to happen. And these side effects, they are manageable, but still 7% dose reductions they were seen, and 11% dose discontinuation were seen in this trial. So most of the patients, they had diarrhea, paronychia, dry skin, pruritus, cough, and stomatitis as the side effect of the drug. Few of the patients, they had nasopharyngitis and decreased appetite. So QT prolongation was reported in 7% of the patients who were on osimertinib, and 1% of the patients in the placebo arm. So QT prolongation is one of the things which needs to be watched for. And 3% of the patients, they developed grade 1 or grade 2 interstitial lung disease while on the osimertinib. So we are discussing the post-operative chemotherapy use and the adjuvant osimertinib, whether the chemotherapy usage had some effect on the DFS or overall survival in these patients. Overall survival has still not been reported, but we will be discussing about disease-free survival. So we have a closer look on the overall patients who received adjuvant chemotherapy. So, most of the patients, they had received the adjuvant chemotherapy for a median duration of 4 cycles. It was consistent across the treatment arms. The major patients received platinum-based chemotherapy, mostly in the stage 2 or stage 3, 76% patients they have received adjuvant chemotherapy, and in stage 1B, 26% patients they had received adjuvant chemotherapy. So this is the disease-free survival in patients with or without adjuvant chemotherapy. So those patients who had received adjuvant chemotherapy, the disease-free survival was 89% at 2-year mark and 49% with the placebo arm. And if you can see here, the hazard ratio is consistently 0.16 here. And if we did not have, the patient did not have received adjuvant chemotherapy, still the drug, we can clearly see the difference between the DFS which we can achieve if we are not given adjuvant chemotherapy. So DFS in patients with or without adjuvant chemotherapy by disease stage, almost all the patients, they had advantage whether they had received adjuvant chemotherapy or whether they had not received adjuvant chemotherapy, and the hazard ratio
Dr. Manish, your voice is not audible.
Dr. Manish has disappeared and his voice has also disappeared. So I think someone from the organizer side, please contact Dr. Manish.
Sure, sir. We are just coordinating. Manish sir is rejoining.
वॉल्यूम तो कर वॉल्यूम है
hello.
Yes, Manish.
Okay, you can hear me now. Can you share the screen? I think 3 or 4 slides they are left. So I've joined from a different device. So we had covered this. The next slide, please. Next slide. Next slide. Next slide. Next. Yes. So when we are giving a drug for such a longer duration of time, we need to know the patient-reported outcomes also. We have seen that 7% dose reductions they were there in the adjuvant osimertinib treatment trial, and 11% patients they had permanent discontinuation. Next slide. So this is health-rated health survey SF36, in which the physical component summary was asked from the patient, and mental component summaries they were asked from the patient. The physical component survey, the physical functioning, role functioning, body pain, and general health status was asked. And in the mental component survey, vitality, social function, role functioning, and the mental health was assessed. So these were the 2 summary scores which were taken, and total 8 health domains they were used. The data, it was collected at the beginning, then week 12, then week 24, then week 24, and then subsequently. Next slide.
Dr. Manish, you have 2 more minutes to wind up.
Next slide. So if we see here, the overall the compliance rates with SF36 health survey were high in more than 85%. And if we see the time to deterioration of physical and mental component summary, it was consistently the same across the osimertinib arm and the placebo arm. Next slide. So the adjuvant osimertinib is the first targeted agent in the global trial to show statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2 and 3A EGFR mutant NSCLC. And overall, there was 80% reduction in the risk of disease recurrence or death with osimertinib. Osimertinib versus placebo, DFS rates at 2 years were 89% versus 52% respectively. And adjuvant osimertinib demonstrated a clinically meaningful CNS DFS compared with the placebo. The safety profile, it was consistent with the previously reported safety rate of osimertinib, with mild TKI class effects reported. Next slide. Thank you so much for your patient listening. Thank you so much. So I think we are running short in time, and